project of the Kansas University Hospital Physical Therapy Acute Care Functional Outcome Tool. It's a mouthful. We're just going to, from here on out, short it to the KUH because I'm not saying that 25 times while I'm up here. All right, so one of the primary jobs of physical therapist in an acute care setting is discharge planning. Discharge planning is not just about what we do with the patient. It's a very involved process. It involves lots of different people. For the patient, it involves their health status. It involves their fear associated with all the things that have changed, the anxiety and things that Kristen brought up. It involves their motivation to get better, their goals, and their actual physical ability to do things. It involves the caregivers. What kind of social support does the patient have? If they have an elderly spouse that has dementia, they won't be able to take care of them, so it will require much more work for the patient when they get home. The financial and physical resources are a big part of it. Do the patients have the insurance and financial support that they need to be able to pay for additional help or to make modifications to their current living facility? Do they live in a place that can be modified to meet their needs? My house has 47 stairs. Julie made me count them. It's really hard to go home from the hospital to my house. It just wouldn't work. So there's a lot that has to happen for somebody to be discharged from the hospital, a lot of decisions that need to be made to decide where you will go when you leave. Of course, the healthcare providers are a huge part of this decision. The physicians, therapists, nurses, occupational therapists, any specialists involved, such as neurologists or cardiologists, surgeons if they've had surgery, and if they are going to another facility, who will be taking care of them at that secondary facility, whether that's at home or at a step-down type unit. For physical therapists, Will gave an example of somebody who was in the hospital for 6 weeks. That does not happen often. Most of the patients that I saw over the winter were only seen once by physical therapy. They were medical diagnoses. They would come in, you would see them, they would be discharged within 48 hours or so. So for a physical therapist, you have to be able to come in, make your evaluation, decide what the patient needs today, and then make your discharge recommendation to the rest of the staff members to determine where they will go and what they will need wherever they will be. For the most part, this decision is very subjective because it's based on what the therapist sees when they walk in the room. You're getting input from the caregiver, from the medical staff, and then watching the patient move, and you have to decide what would be the most appropriate discharge location for this patient if they're going home in the morning. There's several different places that they can be discharged to. They can go home. They're done. They can go home but still be in need of further therapy because they can't get out and do the things that they need to be able to do, in which case you would recommend them to another physical therapist to come to their house and treat them. They could be sent to a subacute center. Usually those are patients who are lower functioning or more medically involved and aren't able to take care of themselves at home and still need a lot of intensive help with their daily activities and their medical management. And then acute care rehabilitation is for higher level patients, usually not as medically involved, but they still need very intense treatment to get back to where they were, usually 3 hours of therapy a day to try to get them to where they can go home. I was at St. Agnes Hospital. Like I said, we were mostly doing medical patients, but they looked at this and said, we would like to find a more objective way to determine what our patients' needs are. You have all this subjective information coming from the patient and the caregivers, and then you have the medical input coming in from the other medical staff. But when we look at how well they function, what does that tell us? So they decided to try using this outcome measure. One of the therapists there at the hospital was familiar with it, and she suggested it, to try to give an objective measure to the patient's level of physical function. The KUH is a 28-point scale that measures 4 areas of basic functional mobility. bed mobility, transfers, gait level, and gait distance. They kind of felt that these were the very basic things that a patient needed to be able to function at home. So if you cannot do these things, then you're not going to be able to make it home. This is a picture of the tool. It's basically just graded by how much assistance, with or without an assistive device, the person needs to be able to do a task. So 0 is cannot do it, 7 is they're completely independent. For the gait distance, it's measured by how far they make it, and it's just 0 to 7 for each of those 4 areas. Now the theory was that the more functional ability the patient has, the more they will be able to do by themselves, so the less help they will need wherever they are discharged to. There are lots of functional outcome measures. I think Will listed about half of them. But you also notice that he said in his that it took days to complete them. And sometimes it would take a huge amount of time, and he'd have to rearrange his schedule to get those tests done because they are very involved. Also, a lot of the tests that are used in acute care only measure one aspect at a time. So they just measure walking, or they just measure bed mobility, or they just measure balance. And you have to do several of them to kind of get a full picture of what the patient is doing. So the goal of the KUH was to do something very quick, very concise, that would give you the basics of functional information that you need to determine your patient's ability to go home. Initially, it was developed just to measure their functional ability and then to monitor any changes over time. It was validated in 2008 by a study that compared it to the FEM, if you're familiar with that. And they found that it was a good tool. It did a good job of measuring how well the patient was doing. St. Agnes was hoping that they could use this tool to better predict where a patient needed to go, which is different than what the tool was designed to do, but that's why they decided to try using this tool there, see if they could use it for more than it was initially designed to. So my purpose was to take the tool that was being used on these patients and to see if it did a good job of assessing the patient's functional level in this setting, and to see if it could be used in discharge planning from a hospital setting. So what I did is I took a sample of patients that had been given this test while they were there. They had all been discharged, and the discharge wasn't necessarily based on their KUH score at this time. They were just given the KUH as part of their initial eval when they were in the hospital. I had 48 patients that I did data analysis on as part of my in-service while I was in clinic. And then I compared their KUH score to their discharge location. I also gathered basic demographic data to see if I could notice any trends in that, to see if it changed or if it seemed to reflect their discharge location as well. Outcomes, you don't need to memorize this. So the KUH is divided into 4 basic parts. Rated 0 to 7, total is out of 28. What I found when I started looking at all this data is that the KUH did a very good job of determining or of showing people who went home with no further therapy needs. There was a distinct improvement in functional ability between the people who were just sent home and the people who were sent to further therapy. And specifically, transfers and gait level also showed that trend. Interestingly, the only one that was significant for patients who were sent to subacute was bed mobility. Logically, it makes sense. If you can't move around in your bed and you can't get in and out of your bed, you're not going to be sent home where you're going to have to do those things. Age, length of stay, and prior level of function were a couple of the other things that I looked at that did not show or did not reflect where the patient was discharged to. This is a chart. It's just that first line of the chart I just showed you. You can see a trend, which is what they were expecting to see, that people sent to subacute rehab were lower functioning overall than people who were sent home, but statistically, only the ones sent home without physical therapy were significant. I did not use an acute care setting in my data analysis because I only had one patient available that was sent to acute care, so I decided not to include them in the data analysis. Discussion. The KUH does appear to reflect the place the patient will be sent to. Only looking at a small number of patients, I can't say it's predictive of where you will send them because there's so many other things involved in where a patient should be sent than just their level of function. But it does reflect the patient's ability to move, and therefore can be a useful tool in providing information for you to make an educated decision on where this patient will thrive. There is more research needed. Acute care and adult living facilities were not included in mine, like I said. All of the patients I was looking at were medical diagnoses, so post-surgical, cardiac, all of these things need to be looked at separately to see if it makes a big difference, if the cause of the hospitalization makes a large impact on the discharge location. And because the KUH was just done by whichever therapist happened to have that patient that day, there was no way to determine any kind of inter-rater reliability. So that would be helpful as well. Any questions? Alice.
So I'm wondering, like, why we would use this instead of the FIM, like in your research. And I know we talked about this a little bit earlier, but I did just come up with this question because you mentioned it briefly, and I'm wondering, like, in your opinion, from like what you did retrospectively, do you think this is as reliable, more reliable than the FIM, or more appropriate for specific populations?
The FIM was what was used to validate this study. The mobility section of the FIM is very, very similar to this. The FIM, however, you have to buy it. You have to be trained. You have to train your staff in how to use it. And it is designed to be a multidiscipline approach. It's not something that you as a physical therapist can walk in, take this one piece of information, mobility, and run with it. You have to get information from all of these other departments in order to complete the FIM and actually get a true score on that. So the goal of just being able to walk in during your normal assessment, get an objective number, this would be a better choice. Yes, Rob.
I was wondering if you thought that maybe it was missing balance. That's one thing that, like, a lot of patients I've seen, I feel like balance is a huge thing, and I wondered if you thought that.
It is missing any kind of specific balance scale. You could say probably that the ability to walk gives something of an indication of balance, but it doesn't give any kind of moving outside of your base of support information. So that would also be very useful information. Christian.
You said there's a lot that has to do with discharge planning that goes beyond just the mobility portion.
Mm-hmm.
And so given that, do you feel like you would use this in order to make discharge planning, considering how much else goes into that decision?
I think
I'm wondering how valuable you think a mobility number would be versus, considering all the other things that you consider.
I think it has to be taken for what it is. I mean, it is only giving you mobility. And the fact that, in a way, it's kind of the only one of those pieces of that puzzle that can be quantified. So I think the goal is to just find something that you can measure, and I think it does that. But it would be very much a mistake to say, oh, this person is functional, so we can send them home. You can't move it outside of its intended purpose. Pam. Thanks. Mm-hmm.
Do you know if St. Agnes is also going to be looking at
I think that is the goal eventually. When they did this round, they just they had a staff meeting, they told everyone what they were trying to do, and they said, here's the form, here's how to use it, try it on your medical patients. So since it was a very informal first run, I don't think you could make any kind of inter-rater reliability, but their goal is to implement it across the therapy department, and I think with that information you could get much better reliability information. Yes, Julie?
Savannah, they did this test on the first assessment of the patient, so it was at initial eval, the PTs ran this?
Yes.
And then what about length of stay? I didn't catch your numbers really quickly, but length of stay, I thought I saw like 6 in one of those columns.
Mhm.
The number of days they were staying. So you were still comparing the discharge status or place of discharge disposition to their admission or PT evaluation status, right? You didn't redo the tool.
The ones who were there for multiple days, which I don't think I have it written down here. Yeah. Okay.
That days, the ones who went home.
Yeah, they were there for a certain number of days. It doesn't have how many. There were actually very few who were seen more than once by physical therapy.
So even if they were in the hospital for 6 or 7 days, they said they were seen once and then they were.
And we did have 2 numbers. If they were seen more than once, we had more than one number. 2 or 3 of them had some change, but it never changed by more than 1. So I didn't analyze that separately, but I wouldn't expect that to have a great deal of change just because there wasn't that much of a change in the total score. I mean, if you had somebody like Will's patient who did make a lot of improvement over the time that they were there, I think this tool would actually be much more useful.
Well, and it would be interesting to see too if the therapists who use it really do think it's useful, right?
Yeah.
Because could you go in and make your estimation, all those patients that scored over 20 and you said, yeah, they'll go home, would the therapist have just said, yeah, they'll go home,
Right.
without running this tool?
It was the hospital administration is the one who asked them to implement a objective outcome measure. So that's why they were trying to find one that fit in and didn't tax the therapists into forcing them to do a whole lot of extra tests that they wouldn't be doing already with the patients. Anything else?